every high school we were in, you know,
This used to
30
be a
years ago,
vampire.
when fuel was through the roof, they just started boarding them off with bricks, things like that. You get one window.
That was probably a good thing.
Away.
Yeah, exactly.
Sorry about that.
I think that was a good move. Rob may not like that.
Yeah, Robin's not making it.
I'm good with that.
Text from her.
Good to go, Tom?
All right. Good evening, everybody. It's 5:20 and I need to call this evening's SHS Board Meeting. Let me get up here.
Here you go.
Anyway, let's call to order, thank you. At 5:20, let's call this meeting to order. Let's go around the table here first, because some people haven't met everyone yet here. I guess let's start down with Jeremy.
Hi, I'm Jeremy Adair. I've been here about a year now. I'm the Chief Compliance Officer, and you'll hear more from me in executive session.
I am Leah Allen. I'm an executive assistant to SMG, and I've been here a few months.
Okay. Haven't met you. Welcome. Yeah.
I'm Susan Hodgson. I'm a board member. I've been on the board for a while now.
Shirley Jones, board member. I think I'm going on a while.
Not long enough.
Tony Southern, CEO. Dean Matthews, MCHD Board.
Tom Rice, SHS Board.
Rick Schrader, Chief Financial Officer.
Rob Owens, Director of Plant Ops. Ben Carlock, Chief of Staff.
Lisa Gates, Quality Director.
Karen Labonte, Chief Nursing Officer.
Bridget DeBoer, Executive Assistant. I asked Leah to come so she could meet you guys. She may be covering sometimes if I
Okay.
ever get to travel again.
Leah, we may have met before, but we're wearing masks these days.
Right.
Trying to identify the around as a way to identify people. So.
Exactly.
And thanks for everybody coming together. I know it's been quite a ride over the past few months, but it's good to get people back together. It improves communication, and appreciate everybody trying to be safe too during this time. Are there any public comments? Anybody tuning in here on YouTube that wants to comment about anything? And if it's slow coming in, we can always bounce back to YouTube if we get any questions. But it sounds as though we have no questions right now.
Not at this time.
How many viewers do we have?
It is loading.
Okay, well, that's fine. Let's move on to Dean Matthews for the MCHD report.
We don't have a whole lot to report. Waiting on Labor Day to get the RTU unit installed, so that's the big deal. The other deal that we're working on is the irrigation water that we're in process with NBI for watering everything in the hospital grounds. We're securing the shares of water. We're getting through the city on the utility easement. Ralph and I met today to go over how we're gonna run that line, which, Rob, you're gonna be getting some calls from Ralph. So, trying to allow for what we might want in the future on allowing for teas and things like that, of that nature. Walking around the Howe building, I'm probably gonna present to our board at our next board meeting to try to get some landscaping prices to get that landscaped over at the Howe building, get some irrigation over there and get that kind of looking a little better. That's on us, I think, not on you guys, so, unless you're offering to take care of that. But we'll tackle that one. So, other than that, I don't really have a whole lot more to report unless anybody has any questions for me.
Are we gonna tee off that line as we pull it across?
What we were looking at right now is coming across from Keith Evans, which is over by the storage buildings, coming through right there by the hearing doctor, trying to get into a 2-inch line. So we're gonna put a T in and cap it to feed future lots in case we have other people that wanna tie in. We'll put another T in for Heil, as this be teed in for irrigation for the Heil building. And then I'm hoping that by the detention pond, we have some valve boxes that have 2-inch line. We don't have to come across the main entrance. It looks like it. We're gonna look at the plans on what we did for the patient wing project. And hopefully we'll get that done. We're gonna secure bids for that this fall. So in the springtime, you'll have valves so you can turn it on early through city if you want. And then when it goes to irrigation, you can go back to MBI because they're usually later. You may want to get water on sooner. It just depends on season.
Do we have backflow preventers already in?
Yep, there's a backflow preventer at the main entrance.
Okay.
Yep, so we'll be able to turn those off and on. We'll have to get with the city on that to make sure they're happy, but the backflow preventer should stop that.
Okay.
And yeah, that should be a help on your watering budget.
And we're pretty comfortable that we don't have any other mysterious hook-ins, I should say, to the irrigation system that where we might have to put another backflow preventer in. I mean, how new is this system?
The backflow preventer at the main is where it's always been, right by the main entrance.
Okay.
So past that, I don't really know yet.
Okay.
We've popped a couple of valve boxes today. Looks like most of that's ran with 2-inch, but I don't know. We're gonna look at the plans. I don't know if you know offhand, Rob, if that main line was run 2-inch.
I don't know offhand.
The valves look 2-inch in all the valve boxes. So if that's what we have, we'll have 5 shares of water, and we're gonna purchase another option to be able to get more shares if we want down the line for future whatever. And yeah. Yeah, I mean, we're looking at a couple $100 a year compared to whatever you're paying right now.
Yeah, thank you.
I know. What's that?
2,000.
2,000 a month,
$2,000 a month?
Just for irrigating.
just for the irrigation.
Nice grass.
Like $350 for 5 shares or something like that?
It's not that, I don't think it's that much that we'll be paying for that, but that could be close. The nice thing about the irrigation is you won't be restricted to hours. You can water 24/7. So the water's there, sprinklers can go 24/7. We won't be restricted to nighttime use on the irrigation.
And this is pretty senior water right then too? It's MBIC water, right?
It's MBI, yeah, yep,
So,
yeah. We're having to buy pipeline options from the users group to the north, and then once we have that, then we're securing the water shares, so,
all right, that's great.
yeah,
Well, thank you, yeah.
That's huge.
yeah.
Thank you. All right, anything else for Dean? None, okay. Well, you're welcome to stick around if you want to, or?
Not really.
Come on.
No, I'm just
Nothing.
kidding.
We understand. Thanks.
If you don't need me, I'm gonna head out.
No, thanks a lot.
All
We
right.
appreciate it. Yeah.
Thanks,
All right.
thanks, guys. No, none at all.
Take advantage for the road.
Yeah, no, I'm good, thanks.
Okay,
See ya.
let's move on to Paula Brandon with CHC.
Great. Let me introduce, this is Craig Sims. Let me introduce Paula. Paula is our Vice President for Quality. She was just recently out there doing a mock survey for your facility. So I'm going to ask her to not only share her education opportunity, but also maybe give just a brief overview to the board of how the survey went as well. So Paula, turn it over to you.
Thank you. Good evening, everyone. Can you hear me okay? Hello?
Yes.
Okay.
Yep, we've got you.
Okay, very good. Yes, I'll start with your survey and just say, first of all, thank you for your hospitality. Every time I come to Cortez, It's one of my favorite places to come because your staff is so warm and engaging, and they really want to do the very best that they can. We spent 3 days there and worked very intensely with the staff. It was a very thorough assessment of your organization. And I can say with great pride for you guys that there's been a lot of improvement, a lot of changes going on that we're seeing in the quality arena and the clinical arena of your organization. So I want to compliment Karen and Lisa in particular for their efforts. They've just done a yeoman's work. And I also saw a lot of good things in your medical staff department, along with many other things. So there are a few findings, but nothing that is just horrible. And so I know Lisa and Karen and others are already working on those findings. We will be submitting a report in a couple of weeks to you guys, but overall it was a great survey. So again, thank you for everyone there and all your tremendous hospitality and your efforts. It's very, very clear that you guys are on the move and you're doing good things and you're doing the right things in terms of quality and clinical performance in your organization. And that's what is most important to me. So thank you very much. I'll move on to the presentation tonight, which is called Trends in the Survey Process and the New Normal. Page 2, please. Most of you probably know, but in case you don't, CMS suspended non-emergency surveys in March. However, they did continue high priority surveys such as complaints alleging immediate jeopardy or complaints related to COVID-19. They also are doing or continue to do initial certifications and any unresolved Medicare enforcement activities. Next page, please. Next slide. The primary accrediting agencies, including the state organizations, followed the guidance of CMS and all suspended their surveying for a period of time. However, since then, most of the accrediting organizations have resumed their surveys, many in a limited or a restricted manner. Next slide, please. I'm going to have you jump to slide 7 because what I've done here is these are the different organizations that accredit, but your organization that accredits you is DMV. So I really want to concentrate on DMV and what they're doing. DMV now is conducting primarily remote surveys, except for the reaccreditation survey and or the initial survey. And you all are due around November timeframe for your triennial survey. So very likely they will be on site. I am seeing that in some cases they are not being real prompt about this, or they are delaying, particularly if you are in a high COVID area. And so I'm not exactly sure what they'll do, if they'll come on time or if they might slightly be delayed in your area, because you have a fair amount of COVID in your community, but certainly not like some facilities in Texas and Florida and Georgia and places like that. So I would definitely be prepared. Lisa and Karen and I talked about that when we were there. But I do think that you may experience quite a bit of virtual with them. They will probably do virtual meetings, and they will try to limit the amount of time that they are in your organization. I will also comment that if you do have a complaint that the state gets on you, likely they will ask DMV to do it, and probably they will ask them to do it remotely. So either by correspondence with you, written correspondence, or a virtual meeting with you. If you continue to page 8, please. You can skip that slide and go to the next slide, please. So CMS focus has always been, before COVID, on infection prevention. But I will tell you that since COVID, the infection prevention is at a heightened level. And we talked a lot about that while we were at the survey with you guys. Suicide prevention is also still a factor, but not as heavily as they were once focused on suicide, because again, they've shifted their focus almost entirely to COVID. Environment of care before, still environment of care after, and life safety, but the focus is more on how are you prepared to handle infectious disease patients such as the COVID patient, communicable diseases. We're also looking more at the ambulatory environment where you serve patients. So your clinic settings, they're spending more time, again, looking for how are you handling those patients? What are you doing to protect the patient, the staff, and your community? And then finally, I've talked to you before about leadership. And if you receive a conditional finding in any of the areas, then typically leadership also gets a conditional finding. That was a change last year. So you get a 2-for-1 in that case. And you really do want to avoid those if you can. Since COVID, of course, all of the previous infection prevention concerns that they had, plus all the COVID. You have a very nice COVID prevention, infection prevention plan. I looked it over while I was there. I actually borrowed it and took it with me because I thought it was really outstanding. You guys have done an amazing job in that area. And then I'll drop down to emergency preparedness, because they're really looking at how did your emergency preparedness team work effectively to manage the COVID pandemic in your organization. Anytime they're doing a virtual survey, understand that there's risk that arises through that survey because they have more time to spend on document review and looking at things in your organization in more detail. So there's quite a number of changes, but I think you guys are prepared for that. So next slide, please. The specific infection prevention practices that they have concerns and will really focus their attention on are entry into your facility, at the triage and at registration and through your emergency department, looking to see if there's appropriate signage. They also pay particular attention to the visitation policies that you have. And you guys have done a great job with that as well, limiting your visitation and making sure that patients remain in the rooms if they're suspected of COVID, COVID symptoms. Hand hygiene, they're going to be watching, is the staff performing the hygiene appropriately? And are they using the hand sanitizer appropriately? Patient placement is also a factor they'll look at, as well as personal protective equipment. That's a huge one. They have to make sure that not only are you using it, but that you have adequate supplies and that the staff knows how to appropriately use the PPE. Additional things are listed there. They're really looking at the education, screening, and monitoring of staff in the COVID environment. Next slide, please. All of the interest in infection control practice is pretty much the same, but again, the staffing and training, responding to exposures and outbreaks among staff and others, determining which procedures are aerosol generating procedures and what are you doing about that. And I think you guys have a good handle on that. How you're placing the patients, making sure that the infection prevention team is rounding frequently, documenting the compliance related to COVID, and most importantly, keeping up with the changes of CDC, CMS, and other key organizations. Next slide. I think the focus in the future on surveys will be much as it is during this time period. But they are going to focus a lot more on ambulatory care related to the environment of care in those clinic settings and how you're managing your patients. If you're using telemedicine, they're going to be looking at your credentialing and privileging of those individuals that are doing telemedicine and making sure that the communication with the patient is appropriate. And then, as I've mentioned, the latter two, emergency preparedness and planning and document review. Next slide, please. I've kind of alluded to this as well. The virtual and remote survey will give them more time to look at medical records. They like the virtual process because it allows for broader participation of board members and medical staff. If they do it virtually, they don't feel like it's as invasive of your time, and they can do, you don't have to come to the hospital. They can include you in an interview virtually, and they are doing that. So I wouldn't be surprised if you're asked as a board member to participate in a virtual interview when you are surveyed. And then finally, the document review. They have time to do very comprehensive reviews when they're doing part virtual and on-site survey or complete virtual survey. Next slide, please. The documents that really need to be clean and sharp are your medical minutes and bylaws from your governing body and your medical staff. Any previous survey findings, not only will they look at those, but they'll look at what you've done to correct those deficiencies. Contracts and agreements, primarily they're looking there as, are those individuals, those contracts being held accountable from a quality perspective? And then various policies and procedures that they will want to look at. And there are a few listed here for you to see. Next page, please.
Paula, a quick question for you, Paula. The previous survey findings, or maybe it's for Karen too, have we already gone back to review those previous survey findings and in good shape there? Or?
That's an ongoing process throughout the year. It's always in the forefront, absolutely.
Okay. All right. That's sort of one of the guiding documents. So.
Yeah.
All right, thank you.
We did look at those while we were there, and there are, I think, for the most part, many of those have been addressed. Lisa and I spent quite a bit of time looking at those, and I do believe that there's a few things that still need to be tightened up from a documentation perspective. I think they've been done, but she needs the documentation in her hands, and some of that is still to come. So I know she's working really hard on that. So any other questions about that? Okay. In conclusion, I would just like to say COVID has not only impacted our organizations from a clinical, financial, and human resource perspective, but I believe that COVID will likely impact our survey process for years to come. There will be continued emphasis on infection prevention, emergency preparedness, looking at a broader scope, not just inside the hospital, but your extensions of your hospital, for instance, in your clinics and any other community things that you do with or might be involved in. And then the role of your leadership in the organization. And leadership is not just the administrative team, but equally as important and is the board and your function in the organization and how you work with the team to help them be prepared for any of these types of emergencies and pandemic events. Hopefully not too many pandemic events. And then the next slide is really just questions, if anyone has any questions.
I don't have any, I guess, or a comment that I believe that the board is open to, or at least approachable for any help that we can provide. But my opinion is that you guys are a tight ship, and you don't have to ask us for anything because you have a good approach. But from the findings, it sounds as though everything is moving forward smoothly. Well done.
All right, and then
I think it speaks highly to the type of leadership and the type of good communication that's going on all around here to make sure that you're achieving all these things.
Yes, absolutely. You've got a great team there. And then the last slide, I'm just going to say, and I think we all know this, the next slide is just, welcome to our new world, because we are certainly in a new world related to surveys, related to quality in our organizations, and clinical excellence. And you guys are right there among the top leaders. So thank you very much for your time.
Any more questions for Paula? All right, well, hand it off to Craig.
Thanks, Tom. Paula, thank you again for the time for all that. And again, congratulations to the whole team, Tony, Karen, the whole team. That's one of the things we do on an annual basis. So we continue to monitor, that as part of our services. Really, my packet, my reports attached in the packet of information. Just a couple of things I wanted to point out to the board. We continue to have our ongoing conversations with Tony and Rick in regards to the COVID funds and the uses and the sources of those funds as well. And then also we're beginning to, it's hard to believe, but we're beginning to talk about next year's budget and business plans. And Tony and I have had a brief conversation about some things on regional networking, but we'll be working with the team on developing that to present to the board in the near future. But outside of that, I'll be happy to answer any questions the board may have.
I have nothing for you, Craig.
Okay, thank y'all.
Nope. Okay, thank you. All right. All yours.
We have a couple of policies we need to get approved. Bridget, if you go to page 37, when we looked at our fall risk program again this year, we determined that we really needed to divide and tighten up what less than 44 on your Morse fall scores and more than 44 means. And so we wrote the policy around this, but this is the quick review so that people can look at that and know exactly what they need to do based on the score of the patient to help prevent falls. And so this was, it's called SAFE. It's Safe Environment, Assist, Falls, and Education, I believe. Oh, Engage, okay. And so basically everybody that's the highest score would get all the things done on the page, but if you're less than 44, you get just the centerpiece. So we really wanted to tighten that up and make sure everybody understood that.
No, I think it just speaks to, I've been talking about sepsis and blood transfusions since October, and then this has been sort of the next big piece to push out for education for staff, but this will also not just affect clinical departments, but everybody involved. So house-wide education will be pushed out next month as well. So, we've implemented even a falling star to be put out on the patient's room if they're at risk. So anybody coming into contact would know that they're at high-risk fall.
Right, and our next policy is AMA, which is against medical advice. Typically, you'll see that more frequently in the ED, and we are below the 3% threshold. We have had a little uptick of against medical advice on the inpatient side, which we don't see as often, and so we really wanted to tighten up that.
Why do you think that is? Why is there an uptick?
I think it's a variety of reasons. Sometimes people feel like that they need to go home to take care of pets. Sometimes it's, they just feel like they need to get back home to family, or they want to see their health advisor, I guess you would say, in certain situations. So it's a variety of reasons. On the inpatient side, we do keep records of every person who goes against medical advice. Now, the biggest thing when you go against medical advice is to making sure that the patient has decision-making capacity. Because if the patient lacks the capacity to make the decision, which only physicians can determine, then we can hold them at a higher level. However, if you have decision-making capacity, you say, I just want to be discharged as long as we give you the benefits, then, we do let you go for that reason. Now, we have a new product called Dynamic Health, It's an EBSCO product, which is, it's in a policy format, so staff can pull that up. And so you can see the first three links are links to, actually the first two are links to Dynamic Health, which goes through the process by which people should utilize the against medical advice forms and such. And then down below is really just hospital-specific notes and workflows, and that's why this policy looks a little bit different than FALS. So we give some, as far as definitions, because your inpatient and your outpatient is certainly a different type of against medical advice. And if you keep going down, we actually have for elopements, which we do not have really issues with that, thank goodness. That would be where you go into the patient's room and you know they left. So you would need to search for them and then make those determinations of what to do next. So this policy does include physician pieces because they have to document capacity, as well as the nurses piece. So those are two policies we'll need to get approved tonight.
Okay. There's a third one, correct? Oh, I'm sorry, no.
There's just two. I do have one more thing that will need to be approved that went through MEC. So when we have patients that come through the drive-through that want to get tested for COVID, a lot of them don't have a physician order. So Dr. Aiken has agreed that he would sign those orders for us in the electronic medical record. If we have a protocol that's approved based on what we say is our testing regimen, then we won't have to get him to sign everyone. We can just put it in as a protocol. I didn't bring the protocol because it does change based on, the type of test, what's going on in the community. But MEC did approve that we could put those orders in the protocol without him having to sign each one.
Do we want to do that during MEC, or do we want to do that now as part of this policy?
We could do it as part of this,
Okay.
as part of quality.
Okay. And Susan, you had some comments about policy, this particular policy?
No,
Okay, that was something that we'll handle during credentialing?
a little bit later.
Yeah.
Okay.
Okay, and the last piece of our report today on page 45. So when we started doing NRC in October of last year, we do real-time surveys on OR, ED, and clinic patients. And so they actually get a call and they answer questions based on this. And so this is a dashboard of, this is surgery. So you can see we have promoter, passive, and detractor. So this is the same questions that we ask on the HCAP scores, would you recommend? If people are overall rating, if people say 9 or 10, they're out there promoting your facility. If they say 7 or 8, they don't go either way. They don't promote and they don't detract. Anything below a 7 is a detractor. They're out there probably saying things about the facility or, complaining or choose not to return. And so that's how they break this out. It's a little bit different than the overall rating. What they're doing is they're looking at promoter, passive, and detractor questions. And then they give you a total score, which is your net promoter score. So you can see surgery kind of had a little bit of a dip to 60%, and this is based on the database. So, and then we actually came back up and off. So the next one, 2 pages down, is the ED. And so it's been kind of a seesaw right now. And so we've got to really figure out what happened in June compared to July that we really had the influx. And we did have a lower patient volume in June, so that could have been some of it as well. So we did have more time to spend with each patient. So we are looking at that to see how we can get that score back up to where it was in February.
Karen, just a quick question. Is there any thought that some of this just might be the visitor restrictions that?
Probably.
I know there are lots of fits getting thrown over.
Yeah, especially in the ED, more so than anywhere. And you can see we started doing the visitors again about the middle of July, I believe, and so you can see it did start coming back up. And then the last page is clinic. That's okay. I get some power going there. The last page is the clinic. There again in May, what happened? We went to telemedicine, so we started seeing probably a dip from that. And then it came back in June. And so on HCAPS, it's always usually sometimes never. These questions are yes, definitely, yes, most likely, yes, somewhat, and then no. So that's really just a good overview of what's going on in those 3 departments, or those 3
service.
Any questions?
I have none. Okay.
I'm hoping our dip is the low amount of patient volume that we saw in person.
Yeah.
But,
A good healthy climb out of that
Yeah.
valley, though, for sure.
we definitely did.
Big
We looked really good after January. It started creeping up, and then I think we just had a low patient volume.
Yeah, COVID hit.
I think that's indicative of some people's emotional state over the.
Exactly.
Yeah,
Yep.
as well. So, which I think probably has a,
Definitely.
influence on business too.
For sure.
Okay, thank you, Karen. So, we've got three things, that we, need to vote on. The first one would be, do I hear a motion to approve the fall prevention program policy?
I so move.
Okay, is there a second?
Second?
All those in favor?
Aye.
Any opposed? Okay, and Bridget, you're capturing this, I don't need to, okay, thank you. The second one is do I hear a motion to approve the elopement and leaving against medical advice policy?
I so move.
Okay, is there a second?
Second.
All right, all those in favor?
Aye.
Aye.
All right, any opposed? Okay, no. And then the final one, I'm not quite sure what to call it, but I'm gonna call it the authorization to approve the COVID testing protocol. Do I hear a motion to approve the COVID testing protocol?
So move.
Second?
Second?
All those in favor?
Aye.
Aye.
All right, any opposed? Okay, all right, all those motions carry. Thank you. Thanks, Karen, thanks, Lisa. Great job. Kelly, her. All right, Rick?
Okay. Just kind of walk through the narrative pretty quick. Again, strong patient cash collections of about $4.8 million. We did see an operating cash decrease of about $1.3 million. That's primarily due to our having 3 payroll payouts in the month of July. We did see gross AR decrease by about $947,000. Normally happens when you collect cash and write off contractuals. But our net AR did decrease by about $160,000. Non-patient AR decreased by $9,000. Inventory was relatively flat. We did see a lot of insurance renewals, so that's why our prepaid assets went up to $288,000. We had things such as property and casualty, directors and officers policies, things like that. Our long-term investments did show a gain of about $80,000, so the market's coming back, and we did see a slight gain in investment accounts as well. Fixed assets, again, most of that decrease is related to depreciation. We did have about $60,000 in assets that went into service in the month of July. From a liability standpoint, our liabilities did increase by about $435,000. The payroll liabilities decreased, again, that was from through those 3 payroll payouts. Current liabilities did decrease by about $600,000 as a result of booking Medicaid cost report payable of about $60,000 and the realization of $800,000 in stimulus funds. And we're booking those as they're being forgiven and earned. Current earnings, again, month of July, operating a loss of about $420,000. However, we're positive year-to-date at $773,000. EBITDA for July was $100,000, but year-to-date EBITDA approved to $4.3 million on a budget of about $6.24. From an income statement standpoint, again, gross patient AR was below budget by about gross patient revenue was below budget by about $100,000. Net patient revenue below budget, and that's due to some of the shifts in Medicare patients and revenue recognition. And revenue recognition is trying not to have any bad debt, just recognizing what we're expecting to be paid by the payer and or the patient. If you want to look at things, our clinic revenues were about $16,000 above budget, so our providers are seeing more patients either in a routine setting or as a result of telehealth. Total net revenue was about $300,000 in excess of budget. And provider salaries, again, slightly above budget, and staff salaries. We did our second half of our COLA adjustment in the month of July, which took place for the full second pay period. Contract labor was pretty much under where we had been expecting it would be from a budget standpoint, and I believe we only have 2 clinical contract people on site, one in the lab and one nurse, unless we've added somebody else, right, Karen? I think it's, okay, 3 nurses, okay. Purchase services, again, about $200,000. That's some of that stuff's related to some of the IT migration, plus we've done a few construction projects related to our OB nurses station remodel to make it more functional for both the staff and patients, as well as our chiller. Our chiller that basically is sitting on top of our MRI room, so it provides appropriate cooling, so the MRI doesn't, we don't have any issues with that. Salaries above budget by about $231,000, and that's based on some of our PPE, as well as some of our infusion therapy patients. One of the things that we talked about that Paul and Karen were, discussing in the quality as well as the survey review is we're looking at about a 5-month inventory of PPE, which are going to be face shields, face masks, gloves, gowns, things like that. So,
is that higher than normal?
Yeah. Okay. Normally we would have about less than a month. But with our COVID, we decided to ratchet up to about 5 months.
And that's just stockpiling.
Well, yeah, we don't want to see any shortages.
Stay ahead of the game, yeah.
Yeah, there's still about, about 100 face shields in my office, I think. It's in that closet.
Got those, sorry.
Huh?
I forgot to.
No, that's okay. Just
leave them there.
Yes,
We'll need them at some point.
Exactly. So, we're okay. Again, repairs and maintenance, again, some of the purchase services and some of the construction costs. Interest expense and depreciation was in line based on budget. The donations is related to our sales tax that was passed. And then we did receive an emergency management grant of about $28,000. I want to call out Matt Lindsay. He makes grant proposals annually, and there is a $2 registration fee for driver's licenses and things like that kind of pulls everything into the emergency grant. And Matt's been able to argue for things on our behalf. You guys will probably see us arguing for another rig, whether it's either a van or a box, because our current ambulance, our oldest ambulance will age out at about 10 years as of June of 21.
What did that 28 grand fund? Something went right back into EMS.
It's funded a ventilator. Basically, so we bought about $56,000 worth of equipment for about $28,000. So a ventilator and then some other life-saving equipment things that end of life. Yeah.
It's a warmer to warm blood fluid product.
Yeah.
Oh, okay.
One ventilator, some blood warming stuff. Because you don't want to push cold blood into somebody or else it'll...
A couple of life packs, so there's defibrillators that are in the rigs. They cost about 5 times as much as defibrillators in the building because they have to be rough and tumble, I guess you'd say.
Yeah, that's right, yeah.
Yeah.
We do have cold-blooded people.
Yes. So, guys, any questions on the income statement or balance sheet or narrative?
Are we seeing a increase in cost for PPE, face shields and things like that? I mean, people were still getting...
We have been since March.
Yeah.
Yeah.
People are still taking advantage of the situation.
Yeah. Basically, it's supply and demand.
Yeah.
A lot of dollars are chasing, not a lot of goods.
Yeah.
Yes, sir. So we're, basically, we're looking for N95 masks from places like Staples or Office Depot or things like that. There's a lot of emails that hit our inboxes saying, hey, the old joke is like, hey, you want to buy a watch? Now it's like, hey, you guys want to buy some PPE? We're seeing things such as WHA and Colorado Hospital Association have been great about doing angel flights of PPE for us, which has been phenomenal. So they've gotten us face shields, surgical gowns, just hard to get stuff. Surgical gloves, not all gloves are created equal, not all gowns are created equal. So it's been a great organizations to work with, from a PPE standpoint.
Is the staff happy with what they have?
I would say 90%.
I hear very few complaints.
Yes. Yeah, 90% or better, which is not bad.
Okay.
I think them knowing that and that's what we try to communicate, that we've got, like 5 months of inventory. We may try to stockpile another month in as well, but it just depends, because, I mean, if you have something that happens, then that 4 months could dwindle down to 3, so we're trying to, just kind of build a.
Yeah.
We have 12 PAPRs, and I think we have 20 more coming in.
I think so, yeah.
So that we can be prepared by using those as well.
And a PAPR's more or less a full hazmat suit with a respirator and some,
I mean, it just
Spacesuit.
kind of.
more or less,
Yeah. Positive pressure.
yeah.
For people that definitely don't fit the masks and just don't have the ability to be properly sealed, it's their only option for protection.
Yeah. It's like a helmet that you wear riding a motorcycle. That's kind of what it looks like, except it has air that blows through it.
Yeah, I think I've seen some photos, something like that, yeah.
Yeah. The next page after our balance sheet is, basically showing the MCHD sales tax is about $857,000, and we've contributed about $1.25 million towards the payment, for our debt. As you can tell and I have no idea what page number this is.
Sorry.
That's okay.
59?
I don't know.
59.
So basically, that one, go up one. Thank you. So we've got 105 days cash on hand. We've got to be at 60 by end of year. 32 days relate to Medicare advance funding. Outside of that, we'd be at 72 days.
Yeah. Well done.
Yeah. No, I think it's a team effort. So we've got a good bunch.
Yeah, you do. Yep.
Next page is statistics that shows how we're doing with respect to our patient days and our deliveries. Our deliveries are up for the year, which is good, and we expect that they'll probably be up fairly high in Q1 of 2021. We'll have a lot of COVID babies. So, but again, our clinics and a lot of our things are coming back. Our ED visits, increased substantially. So we're getting a little bit closer to our budgeted numbers. Just trying to focus on that. Next page, again, it's after the stats page, we're looking at our operational analysis, which shows where we are from like acid test ratios. All these ratios are things that we're tracking. We're hitting these, so we're adhering to our debt service covenants. The primary one is cash. And again, we've got about $4 million in debt that's going to turn into a grant. It's the the PPP, Payroll Protection Plan loan. So we've got that. And that'll be, again, forgiven throughout the rest of the year. The next page is the statement of cash flows that kind of ties everything out, basically down. If you'll scroll up a little bit, Bridget, shows that we're at 105 days. Yeah, so that's our sources and uses of cash. And then our revenue cycle report card shows that we're our fiscal year to date, our rolling cash average is about 114%. The clinics were at 99%, and we're hitting all of our days metrics. So except for percent of commercial, and those are some things that are still pending appeals, as well as getting a couple of providers that are credentialed. So not too bad from a revenue cycle metrics perspective. And unless you guys have any questions, that's my financial report.
I don't suspect we will see any additional stimulus dollars as we see
I don't think
Congress.
so. I don't think so.
Yeah. I just don't see much action coming out
You get-
along those lines.
Yeah,
Post office is the next one, I guess.
yeah, I mean, when you look at it, we're about 9, 10 weeks from an election. And we don't even anticipate our Medicare advance funding, them maybe taking that back until maybe Q1 or 2Q of 2021, so.
Yeah, okay.
But,
Okay.
who knows what's gonna happen in Washington?
Okay. Thanks, Rick.
Yes, sir.
Great team effort. These numbers look good, I harken back to a couple of years ago, how things were looking then. Continually, that still open. Great job on that.
Thank you.
Yeah.
We got a great team.
Yeah, you do have a great team, yeah. Yep. Any questions about the invoice, the CHC invoice?
It's not in our packet. It's just, that was something you guys approved at Finance
Yeah,
Committee.
right, yeah, it was
Yes.
just on the agenda here. I
Yes,
wanted to
sir.
make sure. Okay, any questions for Rick? Okay, do I hear a motion to approve, July financials as recommended by the Finance Committee?
I so
I
moved.
so
Is there a
moved.
second?
Second.
Okay, all those in favor?
Aye.
Aye.
And do I hear a motion to approve the CHC invoice as recommended by the Finance Committee?
I
I so
moved.
Thank you. Second, all those in favor? All right,
Aye.
none opposed. All right.
Um,
Thanks, Rick, great job.
Thank you.
Carrie, on to you.
Okay, so I have, are we still in public session? Sorry, I joined over.
We are.
Okay, great, thank you for letting me know that. So, I have an update a little bit on the clinics as far as our drive-through testing. We are going to expand the drive-through hours based on the reopening of schools to account for, anyone that we need to catch, in that catchment, including teachers, and students in our district. So, as of 8/31, that's Monday, we will be open Monday, Wednesday, Friday, 8 a.m. to 2 p.m. And on Tuesday and Thursday, we'll be open noon to 6 p.m. to catch those afternoon kiddos and teachers that may not be able to leave school that are symptomatic or have been exposed. So I think that's it for drive-through testing. The other thing that I'd like to talk about is we are transitioning some other tests out to the drive-through potentially as we start to get into flu season and what we're hoping is a steady COVID season and not a spiked COVID season. We will be offering strep testing, flu testing, and then in particular cases RSV testing. The idea behind that is that we would see the patients via telehealth, give them the orders, they could go through the drive-through without ever entering the building. So we are eliminating the risk to our staff members and then also patients that are healthy. So you will see more information on that in the next couple weeks. The other portion that I'd like to talk about is recruitment. Jeff Tarpey and Mariah Tarpey will be joining us in the next month and a half. By the end of October, that is a pediatrician who will be welcomed to our primary care team. Her name is Mariah, and Jeff is a hospitalist who will be joining the hospital side. The other recruitment efforts that we're pushing right now and making efforts and great strides in are sleep medicine. Dr. Rasma is now currently booked out until past November, so we are looking to get him a advanced practice nurse or a PA to supplement that practice and grow that sleep lab and that practice a little bit more. We have a candidate that has run a sleep lab for 10 years and then went back to school to be an FNP, and he is interested in coming to work here for Dr. Rasma. So we're recruiting him right now, and more information will come on that. School-based health. So school-based health opened this past Monday in Cortez. The first day that we opened, we did do 2 COVID tests on site for teachers that were symptomatic. So that is obviously a good resource for our community and definitely for the teachers and all the kids in the RE1 school district. So we will continue to test and evaluate kids at that site. We are open full 8 hours a day there.
Is that rapid test?
We are doing a rapid test for all of the students and teachers. So that is the BD Max test. So you have results anywhere between 8 hours and 12 hours. So we batch them together. We made a decision as an administrative team to do that with the schools as we progressed, because we thought it was important to get those results back quick, and if we could isolate before they were exposing more people, we could do that. So the last piece that I have is anniversaries within the organization. Doug Baggy, our orthopedist, is celebrating 25 years in 2020 with Southwest Health, so obviously a big congratulations to him, and we are thankful for his service and everything that he has done for our community. I'd also like to recognize Brandon Sanchez, who has another big anniversary. It's his 5-year anniversary. He is a family nurse practitioner who is very vital to our primary care clinic and has a great following of patients. So congratulations and thank you to both of those providers. And that's all that I have.
This may be a school issue with the testing and things like that, but my daughter goes to school there, so
Yep.
we get updates from
Yeah.
the school. And I haven't, maybe I've missed it, but I haven't seen something come out of the school. It's really their responsibility
Right.
that discusses these testing options. But
Correct.
maybe
And
Teresa's working on that, I don't know.
they are.
Yeah.
So Cortez in particular will be handing out well, actually, number one, they'll be sending it via email, but I think it's also available in print form to the students. Options.
Okay.
Yep, and that was worked through Sue Cecilia at the Montezuma Cortez School District.
And it is interesting to see to hear how many less students are in person.
Yep.
Sort of a surprising number, but I think
It was definitely a surprise. There was an anticipation that there was going to be 70% returning, and
Yeah.
I think it turned out to be 40%.
Yeah.
So I think it's a good thing, and
It is,
I also think that it will help us to kind of see what this looks like, and then I think as we see hopefully fewer cases and not this big spike that we could anticipate, I think then you'll see more kids probably return in January.
Yeah, it makes me feel a little better that our community actually is concerned.
Yep.
I mean, certainly they're concerned, but that people are taking it a little more seriously
Yep.
than some of us may have originally thought.
I agree.
That's
I
good.
agree.
Yeah, that's good. Okay. And since Rick was talking about the COVID babies, how are we staffed?
Yes, we are.
All right.
We are staffed. We are ready.
All right, any questions for Karen? No. Thank you. Thank you. All right, on to you, Tony.
Okay, just a few things. Let's see, Dean mentioned this. We will start our RTU1 replacement project next week, actually. Like I said, we'll close down surgery after Wednesday's procedures are done, and the plan is to be done and ready to go back in business on Tuesday. So keeping our fingers crossed that that will all work out appropriately. But we think we have a good plan in place at this point to get all that done. So just keep our fingers crossed that everything goes well with that one. We actually got our 2020 engagement survey results back yesterday. So we've just doing some preliminary review of that. Just point out a couple things. We'll actually present this, I think, next month, the full report to the board, but just a couple of the highlights. To remember, our scores were fairly low last time when we did this back in 2019, but for an example, the overall rating as a place to work, the NRC average for that question is about 34.1. We were at 11.1 last time, and we increased that to 24.5 this time. And would you recommend this as a place to work? The NRC average is 46.7. Last time we were at 25.8, and we increased that to 39.3. So the level of engagement increased dramatically, actually, from where it was in the previous survey. Even maybe more impressive was on the physician side. Last time, and let's see, the NRC average was, how would you rate this as a place to practice? The average is 32.4. Last time we were at a whopping 9.1%, and we increased that to 21.7 this time. And on rate this as a place to practice, and would you recommend this as a place to practice? The average is 49.6. Last time we were at 22.7, and this year we actually ended at 56.5, which is actually, I believe, is about the 75th percentile.
Yeah.
So extremely positive increase on that. So, we'll share this entire survey next month, and our plans on how we're going to roll this out as we did last time to the hospital. We're also working on our 2021 business plan. Craig mentioned that earlier. We should be wrapping that up in the next few weeks, and we're presenting that to CHC to kind of bring together some of the loose ends on that. And then I'm not sure if we'll have it next month or in October for the board, but
Probably October.
Probably October, I'm
Yes,
thinking,
sir.
by the time they review it and we get everything done. It's a pretty lengthy document, but we made a lot of progress on that and getting that done so far, so. That's about it, unless anybody has any questions for me.
The survey certainly shows how people have been really coming together in these challenging times, and that's a good trend.
Good trend, yeah.
Can you also talk a little bit about how we've taken some business away from Durango in terms of the sports medicine program?
Yes.
Or
Still in
did I just-
progress, still in
Okay,
progress.
I'm sorry. I hope I did. All right.
We can talk about that later.
Back up.
Executive committee.
Yeah, understood. Okay, we'll talk about this later. Misstep on my part. I
No, that's
apologize.
fine, no problem.
Okay, anything else for Tony? All right, well, let's adjourn from regular session into executive.